Thank you so much for spending some of your time with us here at SAM. They tell you as a speaker to never start a lecture with an apology, but I'm going to break that rule today, and as I explain, hopefully you'll understand why. We are, as a panel, myself and Dr. Brown and Dr. Carpenter, going to go through the current state of evidence as it relates to rapid cardiac evaluations in the emergency department, as well as implementation science. And at the end of the session, we would love, and I will start by handing out a sign-up sheet to engage as many of you as are interested in a multi-center project on doing work like this, where we're going to collaborate and as an interest group provide support from the implementation science perspective. But our fourth panelist is unable to join us. Unfortunately, Rakesh Engineer, if you were at the plenary a few days ago, tragically died last week. So we will do the best we can to present his section of the slides, but bear with us if the information is not as clear as it may have otherwise have been. So our goals and objectives for today. As disclosed to SAM, were to very briefly go over the evidence, to try to talk about implementation science as I had discussed, and then use some sample protocols to see if we might engage you in the audience to work together on this particular topic. So with that said, none of us have any disclosures other than what you can see here. Dr. Brown has done some work on this topic with ASAP and does work with Cochrane Collaboration, and Dr. Carpenter does do clinical policy work with ASAP. So I'm going to step aside and turn everything over to Dr. Brown, and I'm going to make the sign-up sheet available. Certainly do not feel pressured to sign up, but the goal would be if you provide us with your contact information, we will start a group after the session to try to work on this topic together.
Yeah, so the disclosure slide was basically intellectual, what you'd call intellectual potential conflicts. There's no financial conflicts related to this talk. So, you know, the good news is there's been some recently, very recently published evidence to impact building a pathway at your shop. And just this year, we've had 2 robust systematic reviews published in our journals, one in the Annals and one in Academic Emergency Medicine. And believe it or not, they came up sort of with the same answer, which is reassuring. So it's almost like a repetition, you know, of the same process. And both found that the heart score, with a score of 0 to 3, is quite sensitive. Both of those systematic reviews had a sensitivity of about 96% for MACE, or you know, serious outcomes in the next 30 days. So that's encouraging. And then there was also an outcome study that looked at, well, does it really decrease resource utilization if you use the heart score? And they did have a decrease of number of admissions and also length of stay in the emergency room when they implemented a heart pathway. In addition, prior to those publications, just recently the ASAP Clinical Policies Committee came up with a couple statements that would inform your pathway. The level B recommendation, which typically means there's moderate evidence to support such a statement. And if you look at it closely, it's in adult patients without evidence of ST elevation ACS. Can initial risk stratification be used to predict a low rate of 30-day MACE? Basically, the recommendation says a heart score can be used as an instrument for risk stratification. And if the score is, like I mentioned earlier, 0 to 3, it predicts a very low rate of poor outcomes in 30 days, from anywhere from 0 to 2%. We're never going to get to 0, let's face it, and so it seems to be good enough. Now, the other question related to what about high sensitivity troponins, and that we didn't have as robust of evidence to say this is what you should do with a single high sensitivity troponin. There have been a few papers out there. So that's the reason why it's a level C. Level C recommendations don't have, there's some evidence, there's some papers, but a lot of it's opinion based. So they say if the result is below the level of detection on arrival to the emergency department or negative serial high sensitivity troponin at 0 and 2 hours, it's predictive of a low rate. So, okay, you've got a couple statements favoring, you heading in this direction. So what I'm not going to do today is debate the evidence, but we wanted to give you just a flavor of what you would do if you were, building a clinical pathway at your shop on any issue. You'd want to go to the evidence. What do the high-quality systematic reviews say? What do the guidelines, if they're well done, say? And then try to build your pathway around that. And so we just took the first baby step in a couple minutes through the implementation science pathway. And so I think Chris is going to talk about this. Thanks.
Good morning. So I am going to just in about 2 or 3 minutes talk us through some of the implementation science perspectives that you'll want to bring back to your institutions thinking about this rapid pathway. This could be an entire day symposium, and in fact in 2007 it was an entire day symposium. It was the Consensus Conference on Knowledge Translation, and what I'm going to try and encapsulate in the next couple of minutes is what's happened since then that gives you some tools and resources to think about as you go back to your institutions. There's definitely a hierarchy of evidence. We need to look at the highest quality evidence. And one of those earlier slides that Mike showed has a QRL code on there, which is a Dropbox folder that we'll keep open for another couple of weeks with all the evidence if you want to read the original heart studies yourself. There's also competing tools out there. The heart score is not the only one. There's one that's been developed at McMaster. There's another that's been developed in the UK. And there's going to be arguments that come out of why we're using the heart score rather than these other scores. And if you want to read about those other scores, they're in the Dropbox. A lot of the implementation science that I'm going to discuss is in those Dropboxes as well, so you can get more details. But just thinking through the pathway where we get from what we know to what we do, there's so many leaks. There's awareness of the clinicians and those around us, the cardiologists, lab medicine, our primary care colleagues. There's acceptance that we've reached a threshold of evidence where we accept it. There's applicability to my patients. Maybe all these studies are so unique that they don't apply to my patients. There's ability to apply it if they're using high sensitivity troponin, for example, and I don't have that in my institution. I can't use that information in my setting. So just be thinking through those leaks in the pipeline and realize that as we go to change the way things are done in our own shops, we have to think about knowledge of our providers, knowledge of our patients and their families, because we're going to have to share this decision with them and let them know why we're deviating from care that maybe their family got at another time with a chest pain presentation or at another institution across town that may not have adapted yet. There's attitudes of our clinicians. If you look at Rogers' diffusion of innovation, there's going to be those who adopt early, and there's going to be most of our colleagues who adapt when there's a bulk of evidence and they're being swayed that the evidence is now conclusive. And then there's laggards who aren't going to change ever until maybe it affects their pay or their quality assessments. So we have to realize that attitudes and inertia by some of our colleagues are going to be something we need to figure out how to overcome. At the NIH in 2013, we developed this framework that goes through different aspects of adapting behavior and taking evidence to action. And we're not going to go through all this. The original reference is right there from the American Journal of Public Health. But these are things that you're going to need to consider. And we took this 2013 NIH model and it formed the basis of what's called the STARI guidelines now, which is the consort criteria of how you conduct and report implementation research. This was the basis of that report. Just for one example, one of the things that you're going to consider in this model is the reach. So we tend to think in this room about our emergency colleagues, the nurses and the physicians and the physician extenders. But what about lab medicine? They're probably going to need to be on board with anything that you try to implement with a rapid protocol. What about the cardiologist? If you don't have them on board, this could be a disaster. And the primary care physicians, if they don't get wind of what you're doing that's a change, they may be sending the patient back to the ED the next day, which defeats the purpose. So the reach, you've got to think about a little bit of who you're going to incorporate into this. So thinking through some stages, pre-intervention, assess where the evidence is. Are you convinced that it's ready for prime time and you can adapt this into your department? Identify the groups that are going to need to be engaged and how you're going to engage them. Look at where the gaps are in care. What are you going to do differently? Maybe you're already doing this and this is no news to you. Maybe there's some room for improvement. And then think about how you're going to evaluate how this affects your operations and your patients. Is this being done safely? What's the fidelity of it? Are your physician colleagues appropriately discussing this with the patients and helping to communicate and facilitate shared decision making? And then kind of hot off the press, the thing that I really want to think about is de-implementation. It's different than implementation science, but it's probably going to be something you're going to have to do with a subset of your clinicians to break that pattern of a 6-hour trope that's been instilled for the last 20 years. And we're working, we have a model of you may have seen it, a knowledge translation pipeline that we developed in 2007. Mike was part of that group. We're working on a similar figure right now to illustrate de-implementation. Hopefully have that figure done by the end of the summer, but think like a speeding train and how you're going to slow that down and the barriers to slowing down that speeding train to de-implement ineffective or practices that are applied to the wrong patients at the wrong time. So de-implementation is something that you're going to need to consider as well as implementation. I'll turn it back over to Bryan now. Thank you.
So we have about 5 minutes left to again review where we are and where we're headed. The goal of this presentation, as you heard Mike talk about, was a very rapid overview of the literature, and from our perspective, we're accepting the data that Mike had presented about the heart score and suggesting that that's the score that we should use. Chris had spoken about, well, how do we implement that? The last few minutes, what we wanted to do was talk about a couple of institutional experiences in actually doing this. And then again, there is a sign-up sheet that's moving around the room. If this is the sort of thing you're interested in participating, the goal of this session, more than anything else, is a kickoff to potentially collaborating at multiple centers to try to walk through those implementation science steps that Chris had talked about so that your shop can move, if you're not in a heart or other score assessment mode, to do rapid rule out, typically with one troponin, to increase the efficiency in the emergency department. That's what we want to move forward to do. So Rakesh had put together several of these slides. This is an example of one of the protocols that he had come across. This particular protocol is a little bit busier, and you can see it's referenced to my memory from one of the European societies. At our institution, we have, and we use Epic and have dashboarded all of these particular key performance indicators. The heart assessment and initial provider assessment and an initial troponin at the time of that initial provider assessment. If the pain has been going on for 3 hours or more and that troponin is negative and the score is 3 or less, as Mike had talked about, we're discharging them. If that initial troponin was not at a minimum of 3 hours from the onset of symptoms, we will then draw a second one as soon as possible to hit that 3-hour mark. And that is how we're doing it at Lehigh Valley. And we have found that we have dramatically reduced both cardiac chest pain length of stay and use of our observation unit. So again, Rakesh wanted to kind of point out some of these particular highlighted areas here in moving forward. So the last part of this is at his experience, at Rakesh's experience at the Cleveland Clinic. This is what he went through. They started there with a project charter. That was to kind of identify the stakeholders, as you heard in the implementation science section from Chris. These slides are all available, and I'm going to be moving fairly quickly. But you can see here some of the components of the project charter they did there. This was how he really felt he effectively rolled things out at Cleveland, where they're doing the same thing to educate the masses. You heard Chris speak about there's both an implementation component and a de-implementation component. So they did this with handouts, and you see a lot of things listed on the slide. At Lehigh Valley, what we had done is we have a pathway committee. We designed the pathway, and the reality, at least in our shop, is that the majority of the orders are placed by residents. So a lot of our rollout, when you look at the top bullet point there, we used our journal club. So we tried to match a discussion of the evidence to get those residents aware of the current state of evidence and made sure they were aware over multiple journal clubs. We tried to actually explain it to them 3 times till we started to see that behavioral change. Clearly, at Rakesh's institution, he felt that you definitely needed a champion. You needed a person that was willing to go out and explain this. I think of the champion as opposed to this movie, the movie Braveheart. It's that first person that goes out in the middle of the field, usually painted blue. Sometimes you get arrows in your chest from the other side. Sometimes you get arrows in your back from your own people. But you've got to be willing to be out there advocating on the behalf of these changes. You heard me mention earlier about what we at our institution call KPIs, or key performance indicators. If you're going to do this, we have found at our shop for the rapid rule-out protocol, being able to give people feedback, whether it's individual or atomized as a group, has been key in helping make people aware of where we are in this change process as far as length of stays or proportion of patients that were admitted. We even will drill down and give people individual feedback if they're admitting, observing, or discharging based on the heart score they placed into the EMR. And you can see, again, here's another group of metrics that Rakesh has been using at the Cleveland Clinic. So as we start to think about wrapping some things up, the way Rakesh had viewed this at Cleveland Clinic was he wanted to make sure there were some clear deliverables. I think that was his way of managing up. This was a project that was important to his chair, so we wanted to make sure he had the ability to get that information back to his chair, whether the change, as you can see, the bottom here was either a big or a small change. I wanted to make sure we left this last slide up for as long as possible. I've noticed several of you using your phones to take some pictures. This is that QR code that Chris had mentioned earlier. We have posted a very brief handout. It was intentionally meant to be just a few articles on the heart score, and at least when I did the search, I'm not nearly the expert that Chris is, a few articles on implementation science as a handout. There's further detail in the Dropbox, and at this point, we're about 2 minutes ahead of schedule. I'm not sure where the sign-up sheet is, if someone maybe could raise their hand just to wave. So for our colleague in the back, please make sure, if working as a team with us, with the EBHI interest group, with other members of those in SAM that have attended the didactic today, please put your name, your institution, your email on that sheet so we can create a small community. If this is something you're interested in working on at your shop, the goal would be for us to share experiences, try to go through the journey together, and at SAM 2020, compile some of the data we've gathered on the KPIs at each of the shops and report that out maybe as an abstract or a poster. So with that said, I would love to use a few minutes to be back and forth and engaging. What questions might any of you have for my far more learned colleagues or myself about rapid rule-out and troponin? Yes? We do not at our shop. We're using a lower sensitivity of troponin, but we have found we haven't had any bounce backs. We haven't had any MACE events that we're aware of. A lot of my partners are reluctant, I'll admit, to use the heart score of 3 to send people home with a single troponin. So we baby stepped it and started with just a heart score of 0 to 2. And that was based on the feedback we got as we did our rollout, especially, as you heard me mention earlier, our rollout we did at a lot of resident events at journal clubs. So the key educating faculty were there, and they had read the literature as well, and they felt more comfortable with the 0 to 2. But even if we can just get that change done, it's a step in the right direction. I don't know, Mike, if you or Chris want to comment.
Is this working? Yeah, okay. Yeah, I think that's critical. So these implementation processes are back and forth if they're going to work. And so that's great that they were engaged enough to push back a little bit and say, you know what, we're going to do, what did you say, 0 to 2 score. And that's okay. When you get into this, if they're, the end users are part of the process, you're going to be much more successful. And I think Rakesh would have talked about the IT component a little bit. You change the EMR to make it easy for them to do, right? And he did some of that work. That if your pathway can simplify their day-to-day work, it'll succeed. But I also wanted to mention you're all invited to the evidence-based interest group right after this, if you'd like to talk more about this. Some of you might just send an email, that's fine, but do you want to just say where that is, and Brian?
It's Barbados B. It's here on the slide.
Okay.
To continue to answer your question, when we got the agreement around the heart score, it did create a kind of a lingua franca, a commonality. Our department, interestingly, is of emergency and hospital medicine. So at this point, if I have a moderate risk heart score, 4 to 6, I can walk out of the room and call my hospitalist, and they start the process of moving the patient to chest pain obs, even without the troponin being resulted, because the destiny for that patient is they're moderate, they're going to go to them, and then for 7 to 9, we at least touch base with cardiology. Now, our cardiologist's decision to admit tends to be based on the time of day and the day of the week, meaning weekdays they're cool with it when the fellows are in the house, but those other inconvenient times, they respectfully agree to consult and have the hospitalist admit. But we're still finding ways to find efficiencies all over the chest pain spectrum because we engaged these other groups and found a common language around the heart score. So I had an experience not long ago where I walked out of bed 8. The patient had been in the waiting room for an hour or two. They were a moderate heart score. They'd gotten a first nurse troponin and called the hospitalist, and they were out of the department in 45 minutes. It was great. Turned the bed over. Other questions?
I think we have to end.
Thank you. Yes, please.
Do you have anything that you found in the literature that gives some guidance on how to address patients with chronically elevated troponins? Where I work is actually fairly common to have a young person with a heart score of 2 or 3, but they either have some CHF or some end-stage renal disease, usually related to untreated hypertension or something, that you may think this person comes in all the time and would like to discharge them, but they have chronically slightly elevated troponins.
The renal patients as well on dialysis often have chronically elevated troponins, and I have not seen any pathways, to answer your question, to address them. But what you do know is that they've got higher mortality as well, higher cardiovascular mortality. So that troponin is not a leak like we've always tend to think of it. It's a marker of increased mortality. So what I tend to look for is a bump from where they've been before to make my decisions.
At our institution, we would not use that traditional low-risk chest pain pathway because of the issues you identified. So it would be a much more collaborative discussion. Each provider is going to kind of, I think, follow things based on their risk tolerance. But at our institution, we would not apply our rapid rule-out pathway to that type of patient because of the issues you identified. I've been asked by our staff member from SAM who is here to remind you not just to put your name on that sign-up sheet if you're interested in collaborating with us, but to fill out an evaluation. And if I were smarter, I could tell you how to do so, but I'll turn to my colleague that might be able to tell you how to complete a session evaluation.
It's on the app.
It's on the app.
On the app, okay.
Thank you.
There you go.
Thank you all for spending a few minutes with us this morning.